All right, so I'm going to switch to another topic and just a little bit of background to bring people up to speed. Basically, if you have a complete remission, what we now know is half of those patients are MRD negative, half of them are MRD positive. And so without that information, you're really working in the dark. Mm-hmm. And so if you have a look at the green curves here, the green curve is the patient who has MRD negative and CR, but without that, the patients fall down and have an equal outcome similar to just having a partial remission. So that MRD negativity really makes that difference. And so what we need is an integrated approach, and a lot of discussion actually at this meeting is that in this setting, not only do we need the MRD piece, but we also need the ability to immune monitor and assess, is it MRD negative? But also if it's MRD positive, maybe this could be a good risk patient because of the immune status, that we need those two pieces mm-hmm. together. Mm-hmm. So we need to look at MRD negative, and then we need to be able to think about, well, what about the MRD positive? What should we do? Can we stop treatment? Should we change treatment? Very, very important questions. And so the new flow method called next generation flow does add this advantage, which by assessing 15 cell populations, shown with all these different colors here, you can tell if it's MRD negative based on the clonal plasma cells, which are up here. You can tell this is the myeloma, this is not the myeloma. But you can also tell if it's bone marrow. This is the red cell production, and then these are mast cells. If those are there, we know it's a good bone marrow sample. But over on the right here, we can see if there are normal B cells, normal T cells. What is the immune pattern in the bone marrow? And this is a helpful aspect of using this. One can also use the NGS very easily for the MRD testing, but this is an extra piece which is currently of quite a bit of interest. We've done a direct comparison here recently between those two methods. The other thing is that with the NGF, you actually do get information on all the patients. And actually the NGF method is slightly more sensitive. If you have a negativity, this is NGF, but if you are negative by NGS, the sequencing or the flow methods, you have very, very good progression-free survival. So this is the backdrop to what we have. We have good testing. We have the ability to look at a number of aspects. We can design trials where we can look at MRD positive over here, MRD negative, stop treatment, change treatment, and we have a template here of the sort of trials that we're going to be seeing more of. Looking at adduction, consolidation, we can look at MRD all the way along, but we need to answer some of these questions over here as a top priority. So the questions for you are, how do you see the use of MRD testing moving forward? MRD negative, MRD positive. Maybe we will take the top part first and then see how this is going to roll forward into clinical practice. So what's your feeling about MRD testing and clinical trials? What's the key need from your side?
Yeah, I mean, I think there's no question that understanding what to do with the information in the context of clinical trials is really important. And there are two ways to look at it. For the MRD positive patients, do you continue that same therapy or do you switch to something else to drive them to MRD negativity?
Right.
We don't know whether that actually changes the natural history of that disease. We presume it will,
right, but
it's possible that it won't.
Right.
You know, just like there are patients who never achieve a complete remission,
mm-hmm.
but actually do quite well because they have an MGUS-like state and you've
right.
reverted them back to an MGUS-like state. So in those patients, you don't want to keep cycling through drugs saying you're not MRD negative, I got to try something else, when you may be throwing out good drugs,
yes.
and they could be fine.
So you definitely see that as a key need, this kind of a trial,
yes,
looking over
absolutely.
here. Yes.
In the MRD negative patients,
right.
recall that even in the curves from the best trials with the longest follow-up, MRD negative patients are not in a plateau. Mm-hmm. They do continue to relapse.
Right.
And so understanding which patients are still at risk for relapse, mm-hmm. and so you can't stop what mm-hmm. you're doing,
right.
versus which patients may be in that 15 to 20% cured fraction,
right.
and you can stop.
Absolutely. Very important, yeah. So the typical question is, for example, in maintenance, and you become MRD negative, should you stop the maintenance? Well, I don't think we can answer that.
No, I agree. I mean, I'm actually very concerned that people might overinterpret the result of that, or almost equate MRD negativity to a form of cure or a pre-cure. We're just not there yet. And paradoxically, as Sagar has said, you know, we look at our Mayo database, for example, of long-term survivors. So those patients that have lived over 10 or even 15 years, there is that contingent, 15 to 20% of them, who actually have never had a complete remission.
Right.
So we don't want to take that cookie cutter approach and say everybody's got to. You'll get MRD negative and you'll like it. We can't. We can't do that for everybody. But by contrast, I think we're starting to see it in the trials. And the one other thing I would add to the trial matrix that you've put there is it seems in the highest risk patients, MRD negativity is the most important. Those are the ones who don't go back to the MGUS state as much. So that's where it's so important to get the disease down. Because ultimately, you know, we're facing a bit of a crisis with the cost of therapies and the challenge and the potential toxicity of all these drugs together. This could be an interesting way of being able to say, we get you to that deeper response, and then we can take you off therapy. Maybe not cured, but perhaps someone can go on a long period of time off therapy. Almost like we did with diffuse large B-cell lymphoma. We built up a good cadre of drugs. We give the chemo regimen R-CHOP. 60% of people come off treatment after that. Because they're cured, or at least they're cured for long enough that they don't need immediate treatment.
Yeah, so a lot to learn, and as you were indicating in that MRD positive group, we need to define that, understand that, and so this parallel immune assessment can really help us with that, I think. Absolutely.
I mean, but what I worry about is that it's no different than practicing clinicians who say, you haven't achieved a CR, I'm going to change your regimen. You still haven't achieved a CR, I'm going to change it again. And so that, again, you may be cycling through drugs, but not really getting benefit.
Over-treating patients or...
So could I take you to this second question then? I'm sensing that, well, you can tell me. I don't want to prejudge what you might think for your second answer. So do you want to go first on this one?
So I think what we do right now is for all patients at day 100, we check MRD. We also do a PET scan at that time point.
Which is...
Because I think MRD is part of the equation when measured biochemically.
Absolutely.
But I think the imaging piece, as Bart has said for years, is actually an important piece as well. And then we check it at the 1 year and the 2 year and the annual restaging studies. We use it more for information, as you mentioned, with careful education, but we don't necessarily make therapeutic decisions based on it.
Right. So how do you feel about
No,
this?
I completely agree. I mean, I think building databases to have this information is critical. But I think it's important that if the clinicians are listening or patients are listening tonight, getting that MRD status might contribute to our understanding of the disease and what may happen. But to say that we're making a decision to go or no go on more therapy or stopping therapy, it's too early. It's too dangerous.
You don't want to give that implication.
Correct.